الشيطان الرجيم. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. Man la yarham la yurham. One who does not show mercy will not be shown mercy. No one understands pain, especially pharmacologic aspects of pain, especially opioids, some say narcotics, until they themselves have pain. And that is why churi chalao, like that when the knife is on you, then, that may never be on any of us and all of humanity, but when it is, then that person who may be a post-operative patient, a post-surgical patient, or just acute injury, that patient may need pain medication and may even need opioid pain medication. So that's why in pain management, the first is follow the golden rule: do unto others as you'd have done to you. Or la yarham la yurham. One who does not show mercy will not be shown mercy by Allah. So that is the concept of pain management, including opioid or including medication or pharmacologic pain management. Put yourself in the patient's shoes. Pain is the fifth vital, and we have acute and chronic pain. And acute pain is a lot easier. The problem is when it becomes chronic pain with regards to opioids, because that's where you can get dependence, tolerance, and addiction more often. And the suicide rate and the rate of suicide attempts increases precipitously. Opioids, what are they? Well, we'll discuss that and how they're based on the mu receptor. These are medications that go on the mu receptor, and understand the neurophysiology, pain, the opioid epidemic, which is a huge problem, and the exponential growth in opioid overdoses. And then finish with the CDC guidelines 2022 to help our providers and our observers over here. The fifth vital. Unlike the pulse, respiration rate, temperature, or pulse, blood pressure, temperature, and the respiration rate, these are absolute. Easy to quantify, easy to memorize, easy to quantify. On the other hand, pain is subjective. So for one patient, a 9 means that they're about to go to the hospital. Another patient has come and talked to me, and they look almost smiling, and they tell, oh yeah, but my pain is a 9. How do you separate these two patients? Chronic pain is complex, and I mentioned before that acute pain is adaptive. It's the first initial pain, and chronic pain, and then you have subacute pain, which goes up to 6 months, and then beyond 6 months is chronic pain. That's maladaptive, often. And that's where there's a disorder of the somatosensory pathways, the signaling pathways. And often this is related to genetic and epigenetic factors and cultural factors. It's different in a Caucasian or white community as opposed to African or African American community, as opposed to Asian, including South Asian, India, Pakistan, Bangladesh, as opposed to a Latin community. Some are more expressive of pain, and others are less. And a good provider assesses all of these when they when they try to treat a patient. And you may remember that the saying in residency: the longer you stay, the longer you stay. If you're on call, the next morning, the idea is get out of there as quick as possible. Round on all your patients, find out what has to be ordered, order and leave. If you stay too long and the labs start coming back, well, then you're responsible to check those labs. Then the x-rays come back and the CAT scans come back. And pretty soon, it's as if you're doing another call again. So it's the same with pain management. If you prescribe for a day, the chances of that patient being on the same opioid for a year are very low. And 3 years, even lower. But look what happens when you keep giving the acute pain medication, patient with back pain or injury to the shoulder or knee or the neck, and you, instead of going 1 day or 3 days or 5 days, you keep prescribing for 40 days. Now look at the chance of that patient being on the medication for a year. It's about 40%. And 3 years is about 25%, which is much more than if you did it for a day or 3 days, where you were at 5% and 3% respectively. So the longer you prescribe the opioids initially, the more likely you're going to be prescribing for the long haul. Countries then on the flip side as well, another fact is, why is it that we in the U.S. use so much opioids? We're 2.7% or so of the world's population, but consume a very high percentage of the world's opioids. China is about 4 times our size, and I think India has passed China in population, but they're not anywhere to be found on this table, China or India, and they both have a lot more people than we do. And other countries that are close, like Bangladesh and Pakistan, Bangladesh, Indonesia, Japan, they're also not on this. So why is it that some people need opioids more and other nations and other people less? The side effects of the opioids, there are numerous. The mu receptors, nausea, vomiting, many side effects. Mu receptors. This is, we have our science end on this. The cyclic AMP and the synaptic vesicle, the presynaptic, and releases the vesicles release the postsynaptic and through the calcium channels, and we block pain responses. Measured on given on this is the calcium channels, and then the ascending and descending pathways that are mentioned there. The signal comes in, let's say at the knee, upwards through the spinal thalamic tract, and interpreted in the thalamus and then in the somatosensory cortex. Signals then comes down through the periaqueductal gray, again through the spine, and then to the area through the peripheral nerve, and a response is there. So you tap the knee, and then you get the reflex, or you push a needle, type 1 fibers, and you get a response. The short-acting, now what do opioids do to treat this? They block those pathways, the mu receptor that I described just a minute ago. Some of these opioids that are used, morphine sulfate, codeine, Percocet, hydrocodone, oxycodone actually is Percocet, hydrocodone, Vicodin, and there are other formulations. Hydromorphone, also known as Dilaudid in the brand name, hydromorphone, the generic name, oxymorphone, and fentanyl. These are just some of the opioids available. And then there's the short to the long-acting. You can start on the short-acting, but then go to the long-acting later on. Most of you will not do that, but if you ever do, you take the 24-hour usage of the short, and then you add 50% more, and that's your long. That's your long-acting opioid. The reason you do a long-acting, if you do prescribe longer on, is because if a patient is in pain, they take medication, the pain goes away, then they need the medication, and then again they take it. They have pain again, and they take the medication again. This is habit forming. This is what is dangerous. This is what induces this, the tolerance, the dependence, and later on possibly addiction or maladaptive behaviors. This pain, take medication, get out of pain. Pain again, take medication, get out of pain. This is what's dangerous. That's where they come up with the long-acting, which maintains a steady state. And then the short-acting is only used if there's breakthrough pain beyond the long-acting pain, which is about 15% or 10 to 20% of the long-acting. If it gets over 25%, you increase the long-acting again. The idea is not to have that repetitive behavior. Prescribing long-acting opioids, and I mentioned that it should not go over 25% of the short-acting, should not be more than 25% of the long. Opioid abuse. Now, fentanyl and the other opioids, this is the problem. Look at the rate of deaths. Fentanyl and especially heroin are so easily available, especially in the big cities. It's cheap. The purity has improved. The potency has improved. And what happens is when they go after pain management doctors or internists or the surgeons, but especially the pain management doctors, what happens is the opioid prescriptions drop. The Percocets, the oxycodones, they drop. The hydrocodones, they drop. But then the heroin goes up exponentially. And the fentanyl abuse goes up exponentially. And you see it is exponential. It was around 47,000 dead before the COVID in 2019. And then it went to like 73,000 2020 with the pandemic. And then it went to 85,000. And I think now, what was it, 2022 was like 111,000. It's crazy numbers. So you see, one is that if you have, it is true that there's pain, but there's no pain before. It is lack of spirituality that also contributes. And I finished with the CDC guidelines just because that is important for you. One is that there's a non-pharmacologic is better. Try to use non-pharmacologic means. Physical therapy, chiropractic, homeopathic, and acupuncture, which we just discussed. Number 2, use non-opioids. Gabapentin, neuroleptic agents, use muscle relaxants, cyclobenzaprine, and use anti-inflammatories. Number 2, establish realistic treatment goals. Make a treatment plan so that the patient sees an endpoint when you're on it, when you start an opioid. Number 3, Discuss the risks and benefits with the patient. Let them know what they're getting themselves into and if there are alternatives. Number 4, this is the CDC guidelines. Number 4, use the short-acting and try never to get to the long-acting. That's the goal. Number 5, start at 50 milligram morphine equivalents or less, and try not to go beyond. If you have to go up to 90, keep reassessing and try to bring them under 50 and discontinue it. If you go over 90 milligrams of morphine, make sure you have appropriate justification. Number 6, prescribe under 3 days the short actings. Only 3 days, and try to get them off. Try not to go over 7 days. That's when the curve goes up and you see they're on forever. Number 7, assess the risks and benefits at 1 to 4 weeks and then every 3 months of opioids. Number 8, over 50 milligrams morphine of opioids, or if they're on a benzo, in addition to opioid at any dose, give them naloxone. It's a safety feature. If a patient overdoses, you have the naloxone on board that protects the provider and the patient. Number 9, use the prescription drug monitoring program. Look at the registries from all the states and follow them carefully. Some states have reciprocity, mostly in the Northeast, in the Chicago, Illinois area, and on the West Coast. When you go down south, it's a little bit of a more challenging phenomenon. Number 10, check the urine toxicology. Make sure there's no heroin in that urine, no cocaine, methamphetamines, ecstasy, and also make sure they're taking the medication and that not selling that medication and taking illicit substances. Number 11, avoid using opioids and benzodiazepines, your Valium or your diazepam and lorazepam together. Avoid using them together. And number 12 is use behavioral therapy wherever possible and switch the patients over to naloxone or methadone or what we call a partial agonist like buprenorphine, which is a lot safer. Tramadol also is safer, but still can be abused. And tapentadol, Nucynta, actually affects the norepinephrine receptor, not just mu, and that also is safer. In fact, the physicians say that when the shootings took place and 5 were killed in the pharmacy on Long Island, they left the tapentadol on the floor. I think a 19-year-old was killed, a grandfather was 70 was killed, but they will tell you the tapentadol was left on the floor because it has no street value. So try to use those that keep you safer, keep the patient safer. Jazakumullah.